Hello,
Yes, you can start in 10 seconds.
Okay.
am I audible? Sorry, am I audible?
Yes, sir, you're
Yes,
audible.
sir, we are starting this program. Yes, sir.
Yes.
You are visible too.
Go ahead, sir.
Okay. Hello and good evening, everyone. I'm Maninder Singh Rathod from the Emcure marketing team. On behalf of Emcure, I take this opportunity to welcome you all for yet another episode of No Thrombosis workshop series in acute ischemic stroke. We have been hosting this workshop series for more than 2 years now, and that itself talks about how successful this particular workshop series has been. The highlight of this workshop series is the rare, interesting, and the practical cases of stroke thrombolysis that get discussed on the platform. For today's program, without much ado, I would like to get started by introducing our faculty members. So first and foremost, we have our course director with us, Dr. Subhash Kaul. Sir is a senior consultant and stroke specialist at KIMS Foundation and Research Center, Sikandrabad. Sir has been a faculty for 27 years at Nizam Institute of Medical Sciences, Hyderabad, and the former professor and head Department of Neurology and Dean at NIMS. Sir has more than 120 publications in different national and international journals. Dr. Subhash Kaul has been principal and co-investigator of several national and international projects, including the largest single-center Hyderabad Stroke Registry, which was funded by ICMR. Sir has been awarded the State Teachers Award by the Telangana government in 2017. Sir has been past president of several associations, which include the AP Neuroscience Association, Indian Stroke Association, and the Indian Academy of Neurology. Welcome to the program, Dr. Subhash Kaul.
Thank you very much. Thanks.
Yeah. Next we have our first moderator for the program, Dr. S. Meenakshi Sundaram. Sir is senior consultant neurologist at Apollo Hospitals, Madurai. Sir has over 20 years of experience in neurology. Sir has been the recipient of Gold Medal and Best Outgoing Student Award for the year 2000 from NIMHANS, Bangalore. Doctor has more than 36 publications in various national and international journals. Sir has presented many papers at various national and international forums. Sir has received Best Research Paper Award at the 10th Annual Conference of Indian Academy of Neurology at Lucknow in the year 2002. Sir has been the principal investigator for many international trials as well. Sir is the editor of the South Asian edition of the book Practical Neurology and has also contributed to many books on neurology. Welcome to the program, sir.
Namaste, sir. Thank you.
Next, we have our guest moderator for the day, Dr. Tarun Nagpal. Sir is director and senior consultant neurologist at Aditya Super Specialty Hospital and Trauma Center at Jabalpur. Sir has interest in cerebrovascular disorders and started the stroke thrombolysis program in Madhya Pradesh in 2009. Sir also has to his credit the first plasma exchange for Hashimoto's encephalopathy in India. Sir has a keen interest in sleep disorders and conducting sleep studies for neurological conditions. Sir has been associate editor for Annals of Indian Academy of Neurology, which is the official journal of the Indian Academy of Neurology for the last 2 years. Sir has also been awarded the prestigious Fellowship of American Academy of Neurology in 2009. Sir has passed the European Board of Neurology exam held in 2021 and has been awarded the Fellow of European Board of Neurology. Not only this, Sir has also passed the MRCP SC Neurology UK examination held in 2021 and has been awarded the member of Royal College of Physicians SCE. Welcome to the program, sir. I would now like to introduce our first speaker for the day. Just a second. Dr. Chetan Chaudhary, who is consultant neurologist at Chaudhary Neuro Hospital, Jalgaon. Sir is winner of Torrent Young Scholar National Award in Neurology 2014. Sir has 8 publications in various journals, and sir also has several memberships, which include life membership of the Indian Academy of Neurology, associate membership of International Headache Society, and life membership of Maharashtra Association of Neurology. Thank you, sir, for being a speaker for this program today, and welcome.
Thank you.
The second speaker for the evening is Dr. Lomesh Bhairod. Sir is neurologist and neurointerventionist at the Brain and Stroke Clinic, Ruby Hall Clinic at Pune. Sir is postdoctoral fellowship in stroke and interventional neurology from Rajagiri Hospital, Cochin, Kerala. Sir has 10 publications in several national and international journals, and sir has special interest in stroke and neurovascular intervention. With this, I would request Dr. Subhash Kaul, who is our course director for the evening today, to take it over from here for his initial comments and taking the program ahead with the speakers. Over to you, sir.
Thank you, Maninder. Thank you, Maninder, for setting the context. It's a great pleasure to welcome all the speakers, chairpersons, and delegates. Dr. Tarun Nagpal, Meenakshi, Dr. Chetan Chaudhary, and Dr. Lomesh. In addition to sharing the cases of stroke, which we do month after month, one of the exciting things about this program is that we become aware that how deep and extensive the stroke treatment network has become in our country. Nice to see in small districts, Delgaon, and so many other places, stroke thrombolysis is happening actively. You know, last time we have had cases from Bidar, we have had cases from Nanded, and that is the actual aim of the stroke treatment. Stroke treatment is something which is not restricted to super specialty hospitals. In fact, it will be too late. Stroke treatment has to be given stat at the place where the stroke occurs. That's the ultimate aim. And I think through this forum, we have really seen very, remote areas, how people are, they are the real champions of stroke. People sitting in the big hospitals are not champions. The people who are in the field, who are, despite the limitations and difficulties, managing to treat stroke are the stroke champions, real stroke. So with that, I request our today's brilliant chairpersons, Dr. Meenakshi Sundaram and Dr. Tarun Nag, I think it's Tarun Nag, to take it up from here. Dr. Meenakshi and Dr. Tarun.
Thank you for the
Meenakshi.
opportunity, sir. Thank you for the opportunity, sir. Waiting to learn from you and from the speakers and my co-chairperson, Dr. Tarun Nagpal, sir. Thank you very much, sir.
I think it is will be a wonderful opportunity to have two of the cases from people who have treated those. So I think with the permission of our chairperson, Dr. Subhash Kaul, I invite the first speaker, Dr. Lomesh, to present his case.
I think, sir, Dr. Chetan would be presenting, no? That's Maninder, who is presenting first?
I mean, the way I introduced it was Dr. Chetan first, but I mean, we can do it anyways.
We can go ahead with Dr. Chetan, no issues, sir.
Yeah. Then it's fine with us. Dr. Chetan, are you ready for with the case?
Yes, sir.
Okay, please go ahead. Please go ahead.
Very good evening to my respected seniors. My screen is visible to all.
Yes, sir, your screen is visible.
Yeah. Yeah, so now I am starting the case. I am Dr. Chetan Chaudhary, practicing at Jalgaon. This 45-year-old male with no premorbid illness. He presented at 2 hours from the onset of symptoms with right side hemiparesis, right upper limb and lower limb weakness, and inability to speak. His power was 0 in right upper limb and lower limb. He has history of going out in scorching sun in the afternoon, and he denied any addiction, and there is no family history of any vascular disorder. He doesn't have diabetes or hypertension in past. So on examination, his pulse was 90, regular pulse, blood pressure was 130/80, temperature was normal, random sugar was 180 at the time of admission. He was conscious, he was comprehending partially with comprehension was partially preserved with motor aphasia. Power was 0 in upper limb and lower limb. There was no gaze preference, and NIHSS score was 13/42 at the time of admission. This is the CT scan at the admission. Subtle hypodensity is seen in right basal frontal region and the left basal frontal region, and left MCA looks hyperdense on the CT scan. So this is I'm sorry, but this video is not playing.
So this is a video, is it?
Yeah.
I think then
RX events, can you just guide how to go about it?
You can play it from the folder now.
folder, yes, instead of that.
The
Sir, what you can do is you can try clicking this yellow bar that you see, the cross on the yellow bar. Maybe that is creating the problem.
no, the play button appears at the bottom, but it is not appearing here because of the.
Sir, just a moment. Have you changed your folder? I mean, from which folder you have
Yeah.
added this video? That's why this video is not playing. In whichever folder that video is, you can play it directly from there.
Just a minute. Actually, I am playing it from different laptop. That is the issue. So he was comprehending partially.
Sir, it won't play unless and until you have a video in the same folder in which you have the PPT.
I will try to make it. Will not play.
So Chetan, do you have the video in the same computer from
No,
which
I
you
have
are?
it in different computers, sir. I will just play it afterwards.
Okay, you can describe the deficiency.
Yeah, his right upper limb and lower limb power was 0. He was comprehending partially, but there is no speech output. Speech output was 0. So comprehension was partially preserved, and there is complete motor aphasia. No gaze preference.
So if you
I
could
have
just
go
put
ahead
the
with
slides on full screen, that will be good.
yeah.
Yes, sir.
So I have thrombolized him with tenecteplase 0.2 mg per kg at 2.5 hours, and rosuvastatin 40 mg was given. Meanwhile, his routine blood investigations have come. Hemoglobin was 7.4, sugar was 120 on blood reports. LDL cholesterol was 90. And because of his low hemoglobin, I have sent his iron studies, which shows severe iron deficiency on the iron study. ECG, 2D were within normal limits. Coagulation profile was normal. So on second day, I have done his MRI brain with angiogram. MRI shows patchy infarcts in the left frontoparietal region. And angio shows complete recanalization of left MC as well as distal branches were also seen clearly in this angiogram. And the cervical ICA and intracranial ICAs also look normal. The MCA which is seen hyperdense on CT scan have been seen completely recanalized on this MR angiogram. So this is post thrombolysis video. His motor aphasia has improved. He started talking. His right upper limb power has improved to 3/5. Right lower limb is still 0/5. And his comprehension has completely improved. So this young man has left middle cerebral artery infarction, probably contributed by dehydration and iron deficiency, with complete recanalization after intravenous thrombolysis. Thank you.
Chetan, can you go back to the CT scan?
Yes, sir.
Can you make it full screen, please? So the frontal hypodensity on the left side.
Yeah.
So it appears quite
Anterior, sir. And on MRI, it is not corresponding with the
at
infarct.
2.5 hours.
Yeah.
Yes. And the MRI does it show anything there at the same place? Is it an old scar? Does the MRI show corresponding MRI?
No.
At the
It
same
is not
cut?
showing corresponding hypodensity. It seems to be here on the CT scan, sir. But it is not corresponding on MRI. Means on MRI, there is no infarct at that place. So this aspect score was very good on the CT scan.
So is there a gliosis or there is nothing there?
So there is nothing there. MRI flare doesn't show gliosis, sir.
So it was an artifact?
Yes, sir.
So do you have a follow-up at 3 months of this patient?
No, he had just came. I have just thrombolized him 10 days back, sir. He has came today only for follow. His power in right upper limb is around 4/5. Right lower limb is 1/5 today.
Okay. Call, sir. How
Yes,
often
sir.
do you see such recanalizations happening with the with tenective place? A large vessel getting, which was appeared as a
I see
dense
about
MCA sign.
about 1/3 of the case, about 30%, 30 or 40% maximum.
That's still a huge number.
Been shown higher, but my experience is 30 to 40. Because
Yeah,
in many
that's
of them, we still have to go for mechanical thrombectomy. But definitely, compared to Elteplase, the recanalization is there, but not in everybody. That we have to know. What is your experience in that? What is your experience?
So full recanalization, I don't think I get. It will be much less than what your figure is. Maybe a quarter, maybe 10-15%. I have not with both ectilize and attractase. I think tenectase is a shade better for large vessel, but still your experience is much brighter than what
the worldwide experience is 30%. Worldwide experience, and we also sometimes are surprised. But as I told you, 70% will not recanalize, 30% recanalize. But I have seen recanalization happening there. There's no doubt about it. That's why I am in favor of always giving IV TPA rather than going direct thrombectomy. Because in those 3%, 30%, those 30% at least you can, avoid a lot of cost and all that, where it may help. So I think this is a good case. This is a good example of the recanalization with the IV tenectase.
The one thing is that he doesn't have any atherosclerotic risk factor as such, and only he has anemia and severe dehydration that might be contributory. So can that have positive impact? Means that etiology of thrombolysis.
What is his
Means he doesn't have atherosclerosis. He has just thrombosis.
What is his homocysteine level?
Homocysteine was normal, sir, 27.
And he's not a smoker?
He is not smoker, non-alcoholic.
But have you looked after? Have you done his transesophageal echocardiography to look for patent foramen ovale?
No, sir.
So you don't know, no? He has to be investigated. In young strokes, PFO has always to be ruled out.
Yes, sir.
But you are right. In one way, you are right that this patient doesn't have atherosclerosis. The atherosclerotic vessels are difficult to open. They don't open. Even if they open in a very shaggy way. So this means it is a fresh thrombus or an embolism somewhere. And dehydration could be one of the theoretical reasons it can be. You may be right. That may be possible. But we have to rule out, before we can be sure about it, we have to make sure that he doesn't have underlying PFO. So, Meenakshi, are you there?
Yes, sir, very much, sir.
Please give your expert comments.
Sir, can I have some doubts to ask him, sir?
Yes, please.
Sir, usually we say that stroke is produced by polycythemia, venous strokes. So, and even in anemia, when you look at that, CVTs are common. So here he has shown a patient who has got a significant anemia and a stroke. So my first doubt is that, is there a link between the two? Did we do a sickling test to see what's the type of anemia, or is it established that it is only iron deficiency anemia? Because in those olden times, one of the treatment modalities for stroke, I was told, is to do a phlebotomy to achieve a hemodilution. So if it is this case, severe anemia and stroke, what is the link here? That is one doubt I had, sir. The second doubt I had is regarding the scan. Now, when you have a severe anemia, you may not even get we have two images in this patient. One is a CT scan at the time of stroke, which was supposed to show a dense MCA sign. And the second was a completely recanalized vessel, which was shown on the day 2. So when we have a severe anemia, how common will be able to pick up a dense MCA sign in this patient? So these are two contradictions which went through your mind, sir. I thought I will put up in this forum for me to get a clarification from you.
Chetan, you would like to take up queries? Or they are your questions also?
No, sir. Yes. The anemia, I have seen CVST with severe iron deficiencies anemias without any other risk factor. I mean, thrombophilia profile, homocysteines were normal, and they have severe iron deficiency anemia. In this case also, he doesn't have anemia was iron deficiency only. He has very low ferritin level, serum iron was very low, and PIBC was very much increased. And his peripheral smear was also showing hypochromic microcytic picture.
What was the platelet count, by the way? Platelet count?
Yeah, that is good question. Platelet was 3,50,000, sir. It was not increased. Means there is no thrombocytosis as such.
Usually they are associated with thrombocytosis.
Yes, sir.
So why this patient with severe anemia developed stroke, sir? It's arterial stroke that too. We can accept a venous stroke, no sickling, and only a venous and an arterial stroke. It really, it puzzles me when you look at this case.
I think the anemia has to be investigated. Do we know what is the cause of his iron deficiency anemia?
Yeah, he has bleeding piles, sir. He has issue of bleeding piles.
Okay. So there is an obvious cause. So anemia is known to be one of the risk factors for mainly venous stroke, very rarely arterial stroke, but mainly venous stroke. But those particular patients are associated with thrombocytosis. I myself
Yes,
seen some patients. They are associated with thrombocytosis. That is thought to be a mechanism in them, reactive thrombocytosis and then causes. So here,
yes,
I think we don't know. This is just an association. We don't know whether it's causative or not. It may not be causative. Cause may be somewhere else. We have not done his TE. We have not fully investigated him as of
yes,
now.
sir. Our plan is repeat.
What about antiphospholipid antibody syndrome and all those things you will have to see.
I have
like any other
planned
young
all these
stroke.
investigations on follow-up.
Yeah.
He had just discharged few days back. So
Our
this is the
teacher-
pre-thrombolysis video I would like to show and post-thrombolysis
One
video.
minute,
please,
Dr. Chetan.
Meenakshi.
One more
Meenakshi,
question.
go ahead.
Professor Dr. K. Srinivasan, our teacher here at Madurai, used to tell us that fibrinogen level is very important. And this is in context with the same thing which you mentioned, anemia and venous thrombosis. Was the fibrinogen level checked in this patient also, sir?
No, sir.
Has it got a role?
Fibrinogen level I have not checked, sir. I was not aware of that thing.
This is one of his teachings to all of us. And the second thing is that, sir, are the scans comparable, sir? The first CT with an anemia still showing an MCA, dense MCA sign. Is it an artifactual thing or is it really it's seen, sir? Can you add a scan there?
Yeah.
What about, and please show us the MRI also, pre-thrombolysis MRI.
So pre-thrombolysis, he doesn't have an MRI, so only CT, and then lies on day 2 is when he had an MRI. Correct, sir?
Yes, sir.
So no, but do we, other than hyperdense MCS sign, do we have any other vascular imaging?
No, sir.
Other than
Only on
that
MRI,
is, yeah, no, that's all right. But this is basically we are learning from each other. Meenakshi is right, because this hyperdense MCS sign is not 100% specific test. It
Yes,
has a
sir.
specificity of only 50%.
Yes, sir.
In 50%, it may be just slow flow, or it may be just artifactual. 50% it is. So therefore, we cannot be 100% sure that it was there unless we had a MR angio or a CT angio. Please show this.
So the CT scan to us, sir. Can we blow that up, sir? To show the dense MCA?
Here it is.
No. Can you just make the zoom and just show us? Because I was just curious to only know that point only. The same image, you can just blow it up. That's all. That PowerPoint itself down, you can just blow it. Zoom is there up. Which one, sir?
This one.
Looks to be MCA, but not very dense, but it looks to be MCA only. It's in the same place.
That if you have the image with you there, just to get the Hounsville unit of that in your monitor to be sure about it. Whether it is adjacent parenchyma, one thin strip we are seeing there, or is it an artery? Just you can have a HU unit, will have an idea, sir.
Yeah.
Just a thought, that is all it crosses. So there may be some other mechanism why this patient with severe anemia still has gone on to develop a stroke rather than, this being protective rather. Maybe it is anemic hypoxia which precipitated him, as you said, along with dehydration which led to this stroke. Probably he had an anemic hypoxia overlaying this and a dehydration precipitated stroke. This is what how I would view this case. Sir.
Yeah.
Not sure whether it is correct.
No, possible. How much of dehydration? How much of dehydration he had? He was fasting or something, or he was in hot sun?
No, yeah. What, sir?
Oh, what was the precipitating factor for
Yes.
dehydration?
Yeah. So heat was very high. I mean, his temperature was very high, sir. Environmental temperature, and he has attended one marriage ceremony in the afternoon.
Okay.
So he has been there for 2-3 hours, and then while he has been to his home, he has developed stroke at around 4 p.m.
Okay.
in the afternoon only.
Okay, I think any other point that we need to discuss? No. So,
Sir,
I think
even when you look at the tenecteplase data, I think there was this extend TNK trial, which showed that even in those patients and tempo data, both of them, they showed that before thrombolysis, if you give tenecteplase, a good number of people do not go on to require mechanical thrombectomy.
yeah,
Maybe that is what you have emphasized here. It's a good idea to give tenecteplase in these patients. Probably this is what you have tried to show to us.
yes. But it would have been ideal if we had the pre-tenecteplase vascular imaging also. That would have been ideal. That would be our comment. So, okay, thank you very much, Chetan. Thank you so much. Nice case.
Can
So
I
we'll
show
go-
that pre-thrombolysis and post-thrombolysis video? Sure.
Yeah. That would be nice. That would be nice.
So this is pre-thrombolysis video. So on asking questions to show the tongue, he just opening mouth. So comprehension was partially preserved. On giving command, close the eyes, he is closing eyes. But on giving commands, show your tongue, he is just opening his mouth. So comprehension was partially preserved, and he cannot tell his name. His speech output was 0 at that time, and right side upper limb, lower limb power was 0. And post thrombolysis,
So is that part of comprehension or apraxia?
that is difficult to say, sir. But he was closing the eyes at that time on giving command, and he was moving his left upper limb and lower limb on giving commands. This is post thrombolysis video. Right upper limb is around 2 to 3. So there is significant improvement in his aphasia. That is the most important thing. And right upper limb power is also improved.
Dr. Chetan, I just have one small comment that in case you suspect dehydration, it is better to check the IVC with the ultrasound probe. So you get an idea of the volume status of the person first.
Okay, sir.
And secondly, if we think that it is it is related not an atherosclerotic etiology, then I think the role of rosuvastatin becomes very limited.
Yes, sir. But by convention, we give statin to every stroke patient when he comes. And his
Yeah, I understand.
LDL was around 90 at the time of admission. So the LDL goal is less than 60 in acute stroke.
No, that goal of less than 70 is in those who have got a atherosclerotic disease. But we are saying he doesn't have atherosclerosis. So you can relax in this patient. You don't have to bring it to 70 because we don't have any evidence of atherosclerosis on the MRI.
Yes, sir.
And on this patient, the improvement is more over the upper limbs than the lower limbs, correct, sir?
Yes, sir.
So not fitting into that MCA pattern. So it may be a good idea to do an imaging for him in the future when he comes here, but to see whether it is MCA or AC, predominant involvement. Though every other imaging you showed us MCA, the improvement is not fitting into MCA.
Yes, sir.
And the venous imaging is normal, correct, sir? Completely. MR venogram.
No, venogram was not done, sir, but the flow voids were normal.
Because generally, we will expect the upper limbs to be weaker and the lower limbs to get better in an MCA stroke.
Yes,
Whereas
sir.
now you are showing that the lower limbs are still weaker and upper limb is better in this patient after thrombolysis. Not
Yes,
fitting
sir.
into a typical MCA pattern, but aphasia has improved.
Yeah.
So really, it is not getting into one picture for us. That's why I asked for the venogram also.
But
But
here,
what-
sometimes
MR angio, the ACAs were looking normal, sir. Bilateral ACAs.
No, and
yeah,
the,
I see.
but the left MCA distal branches look little less perfused compared to the right side. If you see the branching pattern of the major branch of the left C, you just see the major bifurcation of the MCA M2.
Yeah.
You know that one of the branches does not look to be very well filled. The top.
Pruning of the vessel,
Yeah.
the distal MCA. But only the improvement is again puzzling, Dr. Chetan, sir. That's what I would think. I would definitely get an MR venogram, however uncommon, because there are many uncommon things here. A severe anemia still having an ischemic stroke. Severe
Yes, sir.
anemia still acute arterial stroke. Severe anemia still dense MCA sign. And then MCA and still the lower limbs are improving. If lower limbs are not improving, upper limbs, though the ACA appear is normal. So I'll
Yes, sir.
definitely get a venogram also to be sure that we are on the right track.
Yes, sir.
Is that okay, sir?
Yeah. But the infarct is the infarct looks to
Arterial.
be patchy infarct arterial distribution.
Arterial only it appears.
Yeah, and MCA actually because it is.
It appears MCA typically.
MCA typically watershed zones are affected and that boundaries of that. So it looks like infarct, arterial infarct. It's a rare presentation, but very very nice.
Here one deep spot is also present, sir, here. In the near caudate nucleus, means in the internal capsule somewhat.
Yeah, you have to find out what is the cause of this. If we do, and at this stage, it is a ESUS, embolic stroke of unknown significance, unknown source. At this time,
Yes,
here,
sir.
I would strongly say you have to do the TEE and rule out any underlying cause there, PFO or something like that.
Yes, sir.
Because your vessels are all right. Your
Yeah.
carotid artery is all right.
Yes, sir.
And yet this infarct is in the typical distribution of the MCA and with a proximal source. Now, this thing can also be found in hemodynamic strokes, But for hemodynamic strokes, usually we need to have stenosis, usually underlying stenosis. Don't have.
And he doesn't have hypotension or means he was not hemodynamically compromised.
Yeah. Anyway, a lot of questions. I think maybe in some future time you can update us about it. But nice case, good outcome. But he needs still physiotherapy for his lower limb. Okay, Meenakshi, can we go to the next case? Thank you, Dr. Chetan, once again.
Thank you, sir.
Shall we proceed for other case?
Yes, sir.
Yeah, thank you so much. Thank you, Chetan. Thank you, organizing team. Thank you, sir, for giving us the opportunity to talk about different kinds and different scenarios. I'll present my case. Is my screen visible?
Yes, sir, your screen is visible.
Okay, thank you so much.
But it's only half of
But,
it.
but sir, we can't see the full screen. I mean,
Okay.
the content is zoomed a lot.
It's too much zoomed in.
Okay. Now?
Yes, sir, now it is perfect.
Okay. Thank you so much. So we'll move on to the next talk is the daily stroke thrombolysis with tenic replace. So this was a 49-year male came to the emergency department of Deshpande Hospital at Baramati. Baramati is a taluka place in Pune district in Maharashtra with complaints of acute onset of left upper limb and lower limb weakness associated with facial deviation and dysarthria. One of my senior colleague, Dr. Ashok Deshpande sir, he's an MD medicine physician who has evaluated this case in the emergency department. And the time of onset of stroke was 3 hours and there was no medical history and he has a strong tobacco chewing history. So on examination vitals, pulse were 88 per minute, which was regular. BP was 140 by 80 mm of mercury and respiratory rate was 16 per minute. He was conscious, oriented and comprehension was good. He was dysarthric, right gaze preference was there, right UMN facial paresis, was there, and power was 0 by 5 in upper limb as well as lower limb. His sugars were 138, NIHS was 12, modified ranking scale was 4 on admission and weight was 75 kg. That was done 2-3 days back only. So he remembered the weight was 75. So on CT scan, which is an in-house facility available there in the hospital, they immediately done a CT scan and was informed to me telephonically that patient was in window period and he has only 3 hours of onset and CT was this. So on CT scan, I was not able to see any intracranial bleed. I am not able to see any dense MCA in the right segment. But what I can see, there was a right gaze preference, especially the eyes are towards on the right side. So by assessing the clinical history and just by looking at the scan, I understood that this may be a large vessel occlusion and definitely patient will require immediate IV thrombolysis. So we have given 0.25 mg per kg of IV tenecteplase and total dose was 19 milligram according to his weight, and IV bolus was given. Following this, he was shifted to ICU for continuous monitoring of blood pressure and neurological status. Patient was given option of mechanical thrombectomy considering his high NIHSS and possibility of large vessel occlusion. Though the vascular imaging was not done, the CT scan which is available at their center was only 16 slice, and they do not have any angiography facility in that CT scan. The technicians were not trained to undergo to do perform angiography, CT angiography for the patients. So anyway, the family members were counseled regarding mechanical thrombectomy, and they were explained that after coming to the thrombectomy center, patient will require an MRI brain with angio and thrombectomy as per the need. So the family members decided, why can't we do a MRI study at our in the same taluka place where a MRI machine is available. There are 3 MRI in the same place surrounding vicinity. So they decided to get an MRI brain with angio at their place only. So after the MRI, which was done around 2 hours, maybe after 1.5 hour to 2 hours after that, there was in fact in the right MCA territory, which is corresponding with the ADC value, and there are some flare subtle changes were appeared. Minor hemorrhagic transformation in the infarct tissue has been noted, and surprisingly, the all the vessels of right MCA are very well seen, and the other also. So there is a recanalization in the MCA. However, we are not able to see what was the source, whether it's proximal M1 or mid M1 or a M2 segment. But after MRI brain, they reported to me again, and since the right-sided major vessels were open, so I told them we have to defer from mechanical thrombectomy. The vessels were open right now. So after 4 hours, means after about of IVT, patient started improving, and by next day morning, he was able to lift his hand and leg against gravity. So routine stroke evaluation was done and the treatment was optimized. Follow-up CT was done after 24 hours, and the risk factors were assessed like hypertension and tobacco chewing. So this was the follow-up CT scan for the same patient, which was shows some hemorrhagic component in the infarct tissue. That is, we generally call it as recanalization, good recanalization. And after following CT, we started him on aspirin 150 mg once a day, and monitoring in ICU was continued for next 2 days and shifted to ward and discharged home on day 7. During these 7 days, I have opportunity to see the patient physically, and I have obtained his consent to sharing his video for awareness among the medical fraternity and mass education about IV thrombolysis and effectiveness of IV thrombolysis when it is utilized. So this was the video. The gentleman was very happy to share his consent and give consent to share his video. Now is able to will दोघं हात वर करा. उभे राहा. चालून दाखवा पुढे. ठीक आहे, मागे फिरा. He is subtle weak in the leg, but he is happy that he is not having major deficit. So after this case, we have 4 major questions I have to ask myself. Does tenecteplase open up large vessel occlusions? What is telestroke thrombolysis? Is it safe to administer via telestroke thrombolysis way? And what is the safety and efficacy of tenecteplase when we are giving it remotely? So let us see what is tenecteplase first. It's a thrombolytic agent. It's a 3rd generation 3-point bioengineered RTPA from Altiplase. And the advantage that it has higher specificity for fibrin, longer half-life, reduced binding to plasminogen activator inhibitors, and a single bolus dose can be administered, and fewer major bleeding complications when it was compared with the myocardial infarction trials. So in neurological also, it has nearly same risk of bleeding as compared to Altiplase. So what is the current evidence of tenecteplase in acute ischemic stroke? The meta-analysis for 5 randomized trial was done, and it has shown that it is very effective when the dose was 0.2 or 0.25 mg per kg. Nortest, which used 0.4 mg, was not shown any good results. Even the bleeding risk was high with 0.4. So they stick to 0.25, and the extend 1-ATNK applies the same, that they have used 0.25 mg per kg before shifting the patient for thrombectomy. So they have got non-inferior results to Altiplase. The reperfusion before thrombectomy was around 22% for them. and 90-day functional outcome was better than alteplase, and the symptomatic hemorrhage was same safety. So definitely tenecteplase before thrombectomy was higher associated incidence of pre-perfusion and better functional outcome when compared to alteplase. So and again, the systematic review and meta-analysis shows that the successful recanalization with favors TNK when it is used for large vessel occlusion. And it has been reflected into the clinical practice also by assessing the modified ranking scale that definitely the TNK was favor in patients with LVO. So these all are out of Western country data. We have our own study called 10 Volt, which was published in 2019 with my mentor Gigi sir and my colleagues. So it was a retrospective single center study and 120 patients were enrolled. And aim was to compare the outcomes of two agents in Indian population. And we concluded that the tenecteplase appears to be efficacious alternative to alteplase for stroke thrombolysis and may be better suited to developing countries, considering its low cost and ease of administration. So this was the conclusion from 10 Volt study. During the same time, we were working on does it have better before mechanical thrombectomy? Does it have faster revascularization? The study has been published in Journal of Stroke Medicine. Our whole team was in the same that we collected all mechanical thrombectomy cases. It was again a single center retrospective study, and data analysis was of a acute ischemic stroke who consecutively presented during the study period of LVO and underwent thrombectomy. So the procedural success was defined as post-thrombectomy angiographic pictures of grade TK2B3 recanalization, and the primary efficacy outcome was defined as improvement in more than 4 NIHSS scale at 24 hours, and the secondary efficacy was modified ranking scale at 90 days, and a comparative analysis of tenecteplase and alteplase was done. So what we found is that we have able to achieve the successful recanalization in around 86% of the patient. And there was a significant mean difference between NIHS score on admission and at 24 hours. And MRS score also has a good scale on tenecteplase. And a faster recanalization was achieved with TNK, needed fewer number of passes, and if the procedure was performed under conscious sedation as well. So we have shown that apart from efficacy of alteplase, the tenecteplase works better when there is LVO. So what is stroke thrombolysis or telemedicine thrombolysis? This was the paper published in 2022 in BMJ. They have seen that from 2014 to 2019, the number of teleconsultations for IV thrombolysis was increasing. And as you go more doing the teleconsultations for IV thrombolysis, the onset from door to needle was reduced, onset from CT to needle was reduced, door to needle was reduced, and median onset for needle also reduced. So it is definitely when you go more and more cases for telemedicine, the performance as well as the efficacy increases. So if you see on 2014 and 2019, the graph is slowly increasing when it's in the remote cases. So the clinical effectiveness and safety of telemedicine to facilitate hyperacute ischemic stroke is safe. And it is a solution to the challenges of delivering thrombolysis across large geographic regions, especially in India, with a limited specialists like stroke workforce. There are very few neurologists who can take the decision. There are very few physicians who can take the decisions. And stroke is as like emergency, it can come at middle of night also. So definitely it will help to give more patients benefit when it is provided through telemedicine. So how to increase stroke thrombolysis care by telemedicine? The possible solutions for this will be a hub and spoke model and other centers. And it's a telemedicine company based or hub and spoke, or it can be individual based as well. These are the spoke hospitals, which could be in various district places or in taluka places, where if the patient comes with a stroke window period, they will immediately inform to the hub hospital, and with the availability of 24/7 neurologist, the spoke centers and a hub center can coordinate. And the advantage that it will increase the number of IVT, and definitely the IV thrombolysis will reach to the community. So as Kaul sir said, rightly said, it's not a super specialist hospital where you should require a thrombolysis. It's like only a CT scan is done. It's like an ECG in MI. We decide for thrombolysis. It should be like a CT scan done in emergency and decide for thrombolysis. So what are the tenecteplase workflow advantage related to alteplase? It has shorter time to prepare. It has shortened time to administer. It does not require that second dedicated IV catheter to be inserted, does not require an infusion pump, and shorter time to initiate inter-facility transfer for when IV lytic was administered. And for our country, the TNK could be administered more efficiently in LVOs, permitting faster start of subsequent endovascular mechanical thrombectomy, cheaper cost as compared to alteplase, does open the LVO more than alteplase as we have discussed and seen, and very good molecule to consider for telestroke thrombolytic agent. You just have to give and relax. You don't have to be for 1 hour waiting that the patient should not bleed or patient should not have high BP. Just give, monitor the blood pressure, monitor the neurological status, and come out. I will say that's why if for telestroke thrombolytic agent, tenecteplase will be better drug as compared to alteplase. So with this, I end my talk and I'm open to receive questions from all.
I think that is a very nice presentation. Before we do further comments and questions, just one thing I missed. Before
Yes.
this thrombolysis, we have the vascular imaging before
No,
thrombolysis.
No, sir, we don't have vascular imaging for
Because they
this
didn't have the
case.
CT angio. So that is one thing common between both cases today. I think it happened just by chance. I'm sure it's not by design, but it
No.
is a coincidence that in both cases, we are assuming that there was a large vessel occlusion on reasonable grounds, but then we don't have a proof of it. But other than that, I think it is fantastic, and I agree with all the points which you have said. Over to Meenakshi, please. Meenakshi.
Sir, it was like, being in the midst of a rain, sir. Phenomenal. Really. Salutes to you, really. Showing all our indigenous Indian data was amazing, really, sir. Hats off. Thank you so much for sharing this extraordinary knowledge with us, sir. Really. Two things. One is the telemedicine which you spoke about. It was popular even before this WhatsApp came. My colleague, Dr. Karthik, when he joined, the first thing he did was to take up this telemedicine. Those days, these images were very difficult to send because WhatsApp was not there and we didn't have the speed. But he made it a point to do it. And we got some images from our, like the same urban spoke model which you spoke about. So we have our satellite center. The Apollo Hospital of Madurai is attached to a few hospitals nearby, which includes another Apollo Hospital in Karaikudi. And they started our program thanks to our colleague Dr. Karthik. And the surprise is that, or I mean, expected surprise, I must say, not just surprise, because now a smaller center is doing more number of IV thrombolysis than us.
True.
And now they don't need us anymore. They
True.
don't need us. And very importantly, the patients reach them faster and their improvement rates are far superior to what we have been able to achieve. Their results are phenomenal. In our own place, so-called tertiary center, we don't have the best results which they have in a satellite center. So that's an important thing to really stress about this. This was the data which was actually coming from the Germany also, the telemedicine pilot project in stroke, Bavaria data, the Tempest project. Way back in 2003s and 4s itself, they started it. And now it has really caught on with all of us and we are doing it, sir. That's one important thing which you taught us. We have been doing it. The second thing is that, sir, when we started having mechanical thrombectomy, how far is that center from your place, sir?
It's 100 kilometer. It's a 2 hour, 15 minutes drive. With ambulance, maybe
Yeah,
2 hours.
Here the decision making was that the family was not willing for mechanical thrombectomy. They just wanted to take a chance. Otherwise,
Yes,
we insist that do not do an MRI there because our interventionist, Dr. John, he always says, sir, before I put in the needle, I want to see the salvageable image and then only I would do
correct.
it. So irrespective of whether he has got an MRI done there or not, if it is more than 30 to 40 minutes, he would always insist on doing an imaging unless we are very sure clinically the data is just the same, which is very difficult because most of us at the time of stroke, we don't have an accurate clinical data. Though we are
Very
talking about NIH, it's very difficult to rely on another person's NIH. So always insist we will get the in-house and we'll do an MRI before I take up again, sir.
yes.
That's what we have been doing. But here the decision making was different. Will he go for mechanical thrombectomy was a question asked. So maybe that's the reason why you accepted for MRI there. That's the second comment. The third comment is that, sir, I thought that 16 slice is good enough to do a CT angio. Am I correct or it is incorrect,
Yes,
sir?
it is correct, but the technician
More
was
than
not
four.
trained.
Oh,
technician was not trained. This time when I went, I told the technician, You come at least once or twice in our center. We'll just tell you how to run a CT angio. So they are, glad to hear that. And maybe in the next couple of weeks, I'll arrange a visit for them.
Yeah, amazing, sir. Amazing. Because
Fantastic.
we'll have always, I mean, we'll all now from now onwards quote our data, your data, which you showed, sir. Why quote always is extend the IATNK and all, sir. We'll quote Lomesh data. That will be
No,
more.
sir. It's all my
Right
mentors,
now,
Dr.
that's
Gigi and my
critical.
colleague, Dr. Kaushik's efforts to publish all these data, sir. I'm just a
One of
part
our
of their team.
persons, one of our persons here was also in your team. He is in Tirunelveli, Dr. Muthukumar. We used to talk
Yes,
about
yes,
Dr. and
yes, sir.
phenomenal, sir.
Great data. Great data. I think I had read about these studies, but it's nice to hear it from you, as they say, from the horse's mouth. You know.
Thank you, sir.
Good. So, Dr. Tarun, you have any comments?
Just two things. One is that what they require is the pressure injector, which is not available with many times with the CT scans in the periphery. So the pressure injector is must for the CT angio sequence.
Yes, sir.
Secondly, the stroke thrombolysis before the WhatsApp era, there used to be a workshop in AN where the patient I attended was in Canada and they used to do it from here, how to do an HS scoring. And the important thing is that telestroke means just distance stroke thrombolysis, but there's a difference between audio and video thrombolysis. So you need to see the patient as well as the scans good quality. Just talking on phone does not become a telestroke thrombolysis.
Correct.
So these 2 points are there. And third, I wanted to inquire with you regarding, sir, what we were discussing. In 10-volt study, what was your rate of LVO thrombolysis occlusions going off with the tenective place? How much were you recanalizing?
It was around 22%, sir.
22%.
Yes, sir. It was matching with Extend 1.8 IL, and it was exactly 11% in Altiplace group.
Okay. So, sir, in between us, in between what Dr. Call and what I have seen, so I think that's a reasonable. Thank you so much for the excellent case.
Thanks.
So I think we had very good cases and a very good discussion. Meenakshi, over to you.
Really, it was very nice hearing and learning and putting up a lot of questions in the first case. And then, more answers than questions in the second case. Really phenomenal. Both were really learning cases, sir. Thank you, Dr. Chetan, and thank you, Dr. Lomesh. Immensely benefited by these presentations. Thank you for the opportunity, sir.
Thank you.
Over to organizers.
Yeah, thank you so much, sir. I think we had another very, very interesting episode of No Thrombosis, and I'm sure there are a lot of learnings and take home points for all the audience that has joined for today evening. I would just like to, start the word of thanks. First and foremost, I would like to thank the speakers, the two speakers, Dr. Lomesh and Dr. Chetan, for agreeing to be part of this workshop today and sharing their cases which made this discussion possible. So thank you very much, Dr. Chetan. Thank you very much, Dr. Lomesh, for sharing your cases with us for today's discussion. I also take this opportunity to thank our moderators, Dr. Meenakshi Sundaram sir and Dr. Tarun Nagpal sir, for making this really, really interactive and sharing their very useful insights on the two cases that were presented today. And last but not the least, I thank Dr. Subhash Kaul, who's been a constant guiding light for us, not only for this initiative, but several other initiatives when it comes to changing the stroke management ecosystem in India. So thank you very much, sir, for your constant guidance to us at Emcure. With this, thank you very much, everyone, and we'll meet again next month with another interesting episode of No Thrombosis. Good night, everyone.
Thank you.
Good
Namaste.
night.
Namaste.
Thank you, sir.
Thank you.
Good night. Thank you.
Thank you, sir. Sir, next time also, please keep it on a Saturday only like this, sir. It's very easy to do it on a Saturday than any other day.
Thank you.
Just take my request, sir. That's all, if possible. Thank you very much, sir. Thank you, sir.
Thanks a lot, sir.